here joining us this morning. So I would like to welcome you all once again on behalf of the management, our beloved principal ma'am, Meena ma'am, and our staffs and the students of KK College of Pharmacy. And you all may expect looking forward to an interesting session, isn't it? So definitely it's going to be an interesting session because our guest today is a wonderful speaker. At this junction, I would like to welcome Dr. Babu sir, who's from Vijay Hospital, who's the man behind the progressive success of the organization. I welcome you, sir, who is going to share, who will be sharing the topic. He will be sharing his expert opinion of challenges in the treatment of COVID-19. I welcome you, sir. It's my great pleasure to welcome you all once again. Thank you, everyone.
Unmute your voice, Samita.
Thank you so much, Shanti ma'am. Now I request Dr. Sendil Kumaran sir, Dean of Pharmacy, KK College of Pharmacy, to introduce the speaker of the hour.
Very good morning to everyone. It is my great privilege to introduce the speaker of today's session. Dr. N. Babu sir is graduated from prestigious institution of Madras Medical College in the year 1996 to 2002, and he did his MD General Medicine, the same Madras Medical College, in the year 2005 to 2008. Dr. Babu sir started his career in the various institutions as an in-charge IMU of various reputed hospitals in the city. And then he started as a medical in-charge IMU at Vijay Hospital in 2009. And successfully he has promoted as a medical superintendent from June 2012. And he also promoted as a CMO, Chief Medical Officer, 2012 June onwards at Vijay Hospital. Sir has having many responsibilities on the day-to-day administration of the hospital, and Sir also be in members of responsibilities of all the committees. Sir also enable the hospitals to NABH compliant and NABL compliant organization. Sir also acted as a General Secretary, Indian Medical Association, Chennai, Vijaya since 2014. Sir also holding the position as Infection Control Doctor, NABH Coordinator, Medical Director, Overseas, HIV Consultant, BLS and ACLS Trainer, DNB Faculty also. Sir also having a fellowship fellow in HIV Medicine also. Sir managed, had nearly 12,000 people living HIV and AIDS control. Sir has conducted many symposiums and guest lectures and many training programs at hospitals. He's also consultant positively in H1N1 pandemic during that period. Sir also received award of State Secretary Appreciation Award for Branch Secretary IMA, TIMA Con 2015. Sir also had State Secretary Appreciation Award for membership contribution in the year 2016. Sir also conducted many training program in INTAX, poison data management, also HIV and AIDS precision. Sir also member of IMA and association of other reputed membership in the medical faculties. Sir also published many papers and research presentation in the international conference as well as in the symposium. Sir also fluent in 4 languages in proficiency, and we welcome you, sir, for this series of KPCP webinar series. And for the right person in this current situation of this pandemic situation of today's corona, so we are very eager to waiting your suggestions and how it's going to be the treatment or the challenges in the pandemic situation. Thank you very much, sir, for joining with us with a short notice and spending your valuable time and precious time with us in all our group. Thank you very much, sir.
Thank you, sir. Now I request beloved Babu, sir, to start the webinar program.
Hello, good morning, everybody. Am I audible?
Yes, sir, you are audible.
Yeah. Respected trustees of the organization, respected administrators, and the participants of this webinar. It is really a pleasure to meet you all in this occasion. Though the situation outside is not very promising, it is up to us, the people who are in the healthcare field, to fight for it and to show some kind of positivity for the world that there will be a better tomorrow. So with that short note, we would go on to this today's topic of COVID-19, the challenges in the management. Sir has given an extensive introduction about me. I am a very small person. It's a presentation on its own. Thank you very much for those kind words, Sandil Kumaran sir. And had been into different forums. With respect to this COVID, I should start by saying that we started our preparation way back in, say, January 23rd, expecting these kind of crises which would be arriving. And at that time, there were few eyebrows were raised. People asking that why, Babu, you wanted to think about those kind of possibilities now at January 23rd. Do you think that it will become this thing? The experiences in H1N1 gave a kind of a foresight that what is there to unfold to me. That's all. So it is all boils down to experience. What you have experienced in H1N1, then you have to prepare yourself for the next pandemic or whatever it may be. From then we had started this thing, and I was fortunate to be a member secretary in the expert panel for COVID treatment in Tamil Nadu, and we will be meeting frequently to devise the treatment plan for the state of Tamil Nadu. So the discussion, what we are going to have in the next 45 minutes or 1 hour or so, is regarding few things which I have learned in the past 3 or 4 months or so, with an extensive literature search and an insight into what is happening around the world. And with these kind of, say, past experience and a little knowledge about future predictions, let us go on into the topic per se. So in this session, we will be I will be taking you through. These are the few, say, verticals, I would say. One is COVID-19 overview, because in order to know the challenges of management, you should have a broader view about the basic disease process. Second is the pharmacological management. Third is the supportive therapies. Then medical legal aspect of it, because every disease has a medical legal aspect. Because here, while you are treating with this, say, pandemic, it is not like your myocardial infarction or diabetes or any other, say, lifestyle diseases, because there are statutory laws which apply to it, acts which will be promoted or it will be implemented. So this will be having a lot of influence on effect on the management. So when you think about medicine, medicine is not a process of just prescribing something. It is, say, 360-degree of societal, community-based, psychological, social, and other facets. So whenever we are going to deal or speak about the management of the disease, all these facets has to be addressed to. Okay. In addition to it, the challenge of this COVID pandemic is in variation to other lifestyle diseases. This is particularly with infectious diseases, especially this droplet infection. The fear and the panic of the healthcare person. So our discussion will be based on, first, the disease process per se, a societal or lawful component of what are the other aspects or regulatory parameters that influences our disease process, and third, it is about the danger to the healthcare personnel. So with this thing, we will jump into the topic. As of April 19, 2020, there are more than 2.4 million cases of COVID-19, right? So which will be around, say, 24 lakhs or so. And the deaths is more than 1.65 lakhs. So the thing is that when we are looking into these kind of, say, very frightening aspects of, just a minute. There is some problem. Sorry, could you view some kind of scribblings? No, nothing, na? In the PowerPoint. PowerPoint is clear, sir. Sendil
Yeah,
Kumaran,
clear,
sir.
sir. Clear, sir.
Yeah, clear.
Hello. Hello.
Yeah, yes, sir. It is
Hello,
clear.
sir.
Yeah.
PowerPoint is clear.
That's
Clear,
clear,
sir.
sir.
Okay, okay, sir. Okay, sir. Okay, sir. Okay, sir. Thank you, thank you, thank you. So because there were certain scribblings, sorry for that inconvenience. So as of now, there are lakhs and lakhs of people who are dying. So it gives a sense of awe or a fear among the people that, I mean, what is there for the next? This is Boston Scientific prediction. Whenever there is a pandemic which happens, there are some statistical tools to predict what is there in wait. Okay, but as we could see that, I think the Boston predictions are mostly true. When you look into the chart, you could see that they have predicted that the epidemic will reach its peak during June to July, possibly so. As you are well aware of, and you would have been updated by your media infodemic that the cases are going in, the surge is happening now. Yes, you would be witnessing or otherwise hearing from various sources the non-availability of beds, maybe that people are panicky about getting a beds, those kind of things. So we are in the early part of the surge. Yes, though government and other private practitioners are taking all the measures to contain the pandemic, it is going out of control. That is what we see here. It is almost apt with what we are seeing here. A peak of number of new cases, a peak of total number of infected patients during the month of June to July, and we will be peaking probably in another 1 or 2 weeks. Then after that, depending upon various other, say, situation, environment, or interventions, the peak may stabilize and come down. And obviously, there can be a possibility of second wave of pandemic also. Going into the virus, whenever we look into a virus, first it has to be named, right? This is a new virus. Though we know that coronavirus, there are a lot of members of the family, okay, it has to be named. So International Committee on Taxonomy of the Viruses has named this virus and the disease. The virus is severe acute respiratory syndrome coronavirus, which we call it as SARS-CoV-2, because we have already witnessed SARS-CoV-1, right? So second, the disease is called as coronavirus disease, so COVID-19. So scientifically speaking, whenever we are discussing with this disease, we would say that, for example, say if you say myocardial infarction, so it is an apt way of saying this disease is COVID-19, and virus is severe acute respiratory syndrome coronavirus 2. This is a slide which captures what are the different coronavirus, especially the human coronavirus. As you know that the coronavirus is not limited only to your, say, humans. It is widely prevalent in the animal kingdom. So the human coronavirus has different, say, members, and these members, they are present in animals most of the time. and due to some kind of, say, opportunity, or maybe due to some kind of intervention, they jump into the humans. Then the person-to-person transmission takes place. So this is a coronavirus. As because it is crown-shaped, we call it as coronavirus. And this is a basic structure. Knowing about the basic structure is very important, because then only we can understand that why we are going to intervene, what are the different, pathophysiology of attacking the virus. So it is an enveloped RNA virus. It has membrane protein, it has RNA, it has a nucleocapsid protein, and there are spike proteins. So this is a basic coronavirus, and this is also important when we are looking into the diagnostic aspect of it, right? So whenever we are sending an RT-PCR, what they detect is nothing but your spike proteins or your envelope proteins, okay? So when we look into the disease per se, once it jumps from an animal kingdom to, say, a person or a human being, then the person-to-person transmission happens. Most of the times, as we are well aware that there is a lot of mutations which are happening in the virus, or otherwise they are harmless organisms, they are living with us, we get our flu, a seasonal flu, there are a lot of other viral diseases which comes and goes without making much impact in our, say, day-to-day life. But however, whenever some mutations, antigenic drift and antigenic shift which happens, then there is a possibility of an epidemic or an endemic or an pandemic. So once it acquires the capability for person-to-person transmission, then there is a possibility of either an epidemic or a pandemic, depending upon how many cases across the continents they have infected. Second is that viral shedding and period of infectivity. So this virus gets transmits from person to person through droplet infection. That is proved. There are two other aspects of transmission which is not yet proved or possibly thought of as a transmission process. One is aerosolization. We are not having any concrete evidence of it, but however, there are certain scientific articles projecting the possibility of such an instance, and fecal transmission. Though the virus is excreted in the feces, there is no per se documented evidence that it has a fecal-oral transmission. So as of now, we are limiting ourselves to a kind of droplet infection. Then it comes to viral shedding and your period of infectivity. How long a person can be infective? Usually, once the virus comes, there will be an incubation period of, say, 14 days or so. And after that, there will be a manifestation of the disease. Once the symptomatology arises, usually 7th to 10th day, the period of infectivity comes down very drastically. Why it is important to know this information? It is very, very important to know this information because our interventions, our community practices, our advices, our, say, community-based approach are based on this. How long a person can be infected? Sometimes, though the virus excrete, for example, as you are aware that we are diagnosing it through RT-PCR. RT-PCR finds out the RNA, whether it is a live virus or a dead virus, we do not know, right? So, mostly 10 to 14th day, they become negative. But sometimes people will remain positive for even 28 days, and maximum number of viral recovery, which has been demonstrated by RT-PCR, is 42 days, right? So, but we do not know whether it is an infective virus or it is just a dead virus being excreted. So, coming back to the question of how long a person can be infective, a person can be infective till the 10th day of his onset of symptoms, or otherwise 3 days within the resolution of the symptoms. Risk of transmission, who is at risk? Who is exposed to the person is at risk. How he get exposed? If he goes near the person less than, say, if he goes near the persons, which we call it as social distancing. So they are recommending that at least 1 meter, 3 feet distance is needed at least, or otherwise 2 meter, which is around 6 feet. So these are the few things recommended depending upon the, say, population index, right? So usually we put it as a 6 feet, but at least 3 feet. So if he goes near that, there is a possibility of droplet transmission. So that is one of this thing. And there are certain risk factors or comorbidities of a person which exposes him to acquire that infection. For example, say diabetes, hypertension, CAD, that is coronary artery disease, CKD, chronic kidney disease, obesity, smoker. So these are the few risk factors which makes a person vulnerable or susceptible to get this infection. Environmental contamination, yes, as you know that as because it is transmitted through droplet, it gets a droplet dropped into your surroundings and it can remain active in various surfaces from anywhere between 1 to 3 days. Immunity and risk of reinfection. Once you get the virus, does it mean that you are totally protected against it? We do not know. Actually, we do not know. As of now, we believe that yes, once you get the virus, you are immune to it. But there are few cases of reinfection. So we are in the early stage of finding out what is really happening, whether getting this infection gives us a protective immunity. So we have spoken about the incubation period here and the spectrum and severity of the illness. 80% of the person, they will have an asymptomatic infection, just like that. They don't even develop the symptoms. It comes, it infects, it recovers. No symptoms. Then there is around 20% which we develop symptoms, among which 5% will go in for severe disease, and the mortality is anywhere between 2 to 5%, usually on an average 2.3%, and varies from person to person, age to age. For example, if you say that more than 80 years old, the fatality or the mortality rate will be around 17%. If it is a young patient, it will be around 5%, or maybe 0.5%. But on an average, the case mortality is 2.3%. Risk factors, as I have already told, diabetes, hypertension, CVD, CKD, and other things. Laboratory findings. What will be symptoms? What are the symptoms? Symptoms is fever, cough, breathlessness. Fever, cough, breathlessness. These are the commonest symptoms. In addition to it, there can be fatigue, myalgia. One of the classical, very specific or more say special presentation is anosmia and dysgeusia. So for every 100 cases, we are getting at least 3 or 4 patients just presenting with anosmia or dysgeusia. They are abnormality in smell. They couldn't smell anything, or otherwise alteration in your taste. Okay. In addition to it, there are a lot of other symptoms as well. They can present with diarrheal symptoms. They can present with myocardial infarction, stroke, all other inflammatory process. One extreme of your presentation is shock with your concomitant MODS. Laboratory findings. What are the laboratory findings? Basically, the laboratory findings are leukopenia, elevated pro-inflammatory markers. These are the laboratory findings. With sometimes in MODS, there will be IL-6 elevation. Imaging. As because it is basically a respiratory illness, there are certain characteristics of this COVID-19 presentation. So CT is one of the modality to diagnose COVID-19 even in the absence of your RT-PCR. Sometimes your RT-PCR, because your RT-PCR sensitivity is only 72%. So 28% of the persons might have a false negative. So imaging can be used as a modality to find out the disease, which we use as a screening tool. These are the few stages. First is a viral response stage. Second is the post-inflammatory response. So this is how a person, say, walks through mild constitutional symptoms, shortness of breath, ARDS. So first is your early infection, second is your pulmonary phase, third is your hyperinflammatory phase, wherein cytokine storm and everything is important. All these slides are very, very, very important because we are going to intervene at a different level. Okay, fine. So what are the spectrum of presentation, which I already told? It can be asymptomatic, it can be IL-like, which is influenza-like illness. Third, severe pneumonia and ARDS. ARDS is acute respiratory distress syndrome. Acute cardiac injury in the form of myocarditis, myocardial infarction, heart attack, or cardiogenic shock. Thromboembolic complication, thromboembolism, pulmonary embolism, disseminated intravascular coagulation, cytokine storm and HLH. During the later phases, the person can go into a cytokine storm, which is called as cytokine storm syndrome. Cytokine storm syndrome. HLH is nothing but hemophagocytic lymphohistiocytosis. This is something related to your cytokine syndrome, wherein the morbidity and the mortality is very, very high. If a patient recovers also, they can have GBS-like presentation. How do we diagnose? Current diagnosis would be based on RT-PCR, reverse transcriptase polymerase chain reaction, wherein we are trying to demonstrate the virus. So this is the diagnostic gold standard for diagnosis of your infection. Then serology can be used as a marker for previous infection. Now coming to the management, right? So now we have gone through what is a virus. It is a beta virus. It is a beta coronavirus, RNA virus, envelope, spike proteins, transmission, then how the disease progresses, and what are the way it can get transmitted, in what stage the patient can come to us. So these are the few things which we have discussed. So this will give an understanding about the drugs what we are going to discuss in the coming slides. So as you know that any management consists of one, overall management of the person. Sorry. So overall management of the person, the patient. Second is the use of specific therapy. For example, every disease has a specific therapy. Now it is a virus, so you should have an antiviral, right? Then third, is there any kind of adjuvant therapies which are helpful, right? Then fourth, then if there is a complication, how I am going to deal with it. Then fifth, there will be certain medication already the patient will be taking, whether this will interfere with this viral infection, right? So these are the few, say, doubts or few questions that arises in your mind whenever we are dealing with the management of the disease. So first about the empirical treatment for bacterial pneumonia. So the question is that, is there any need that during this viral infection, we have to treat a bacterial pneumonia? The documented evidence says that not much of bacterial pneumonia in this COVID-19, but however, based on your procalcitonin level, certain group of patients can develop secondary pneumonia. As you are aware that any viral disease is an immunocompromised state. So there is a possibility of a bacterial pneumonia. Yes, we sometimes cover the bacterial pneumonia as well. Second, prevention and evaluation of thromboembolism. This virus, one of the theory of basic pathophysiology is that it causes intravascular clotting. So most of the guidelines recommend the usage of antithrombotic agents, right? Or anticoagulants. Then managing the chronic medications. For example, say ARBs, statins, and immunomodulatory agents. there are few concerns. When we look into the pathology of the virus, this virus enters the cell through ACE2 receptors, angiotensin converting enzyme 2 receptors. So there is a debate going on that if taking an ACE inhibitor either will increase the incidence of this disease or decrease the incidence of the disease. Till now, there is an inconclusive. But however, according to the present guidelines, we will ask the patient to continue with the ACE inhibitor if he is already on. Aspirin continue, statins continue, right? Fine. When we come to specific management, one is specific pharmacological therapy, then management of your complications, that is hypoxemia, ARDS, thromboembolism, myocarditis, shock, stroke, MI, and ARF. When we look into an antiviral drug per se, we know that a virus enters into the cell and uncoating happens. Either it integrates with your genetic mechanism, for example, DNA, and may compel the DNA to produce its own proteins of its congeners so that it can develop its own offsprings that will cause the bursting of the cell and release of the cell. This causes two things. One is it gives a platform for the virus to multiply, right? Second, it also produces lot of its offsprings which can go and affect the other, say, cells. As we know that various, whether we are treating with your HCV, HBV, HIV, there are various drugs which will be interfering with different mechanisms, say endocytosis, intravascular or intracellular integration, or otherwise nucleotide based transcription, nucleoside based transcription, then protein synthesis. So accordingly, as we are already aware, these drugs are being named reverse transcriptase inhibitors, nucleotide reverse transcriptase inhibitors, non-nucleotide reverse transcriptase inhibitors, nucleoside reverse transcriptase inhibitors, protease inhibitors, integrase inhibitors, right? So these are. So per se, we know that any virus has some kind of antiviral drug. That is this thing. We should go on discussing the modalities or drugs available for treatment of COVID-19 with a baseline fact that till now there is no vaccine or no vaccine is yet available. There is no drug specifically developed for the treatment of COVID-19. All the drugs what we are using are only a repurposed drug, means that we are already, it is being used for some other disease. We are repurposing those drugs for the usage of COVID-19 in the belief that it will contain, and few studies have proven that it has shown some kind of benefit. But till now, there is no conclusive evidence of any particular drug, right? So in this background, we have already discussed certain types of antiviral drugs which are specifically developed for virus. Then there are some group of drugs which has been used as for some other purpose, now being renamed as antiviral drug. Okay, so that is another this thing. Third is that, as we have already discussed, virus comes in, viral replication that causes the disease. That will stimulate your immune mechanism and hyperimmunity and inflammation, leading on to your cytokine storm and also HLH, right? So here you could find two types of things. One, per se, the virus which is causing the disease, then the altered immune response of the body towards the virus, damaging the body. So first, to kill the virus, antivirals, and second, to subdue or to control the hyperinflammatory state. Okay, so these are the two major verticals we are going to discuss. Usually antiviral, as we have discussed, usually targeting the viral function or targeting the cellular function that the virus affects. Based on this, we have nucleic acid polymerase, protease, integrase, neuraminidase, which can be further divided into DNA-dependent DNA polymerase, RNA-dependent RNA polymerase, DNA-dependent RNA polymerase. So what are the potential drugs which are available for treatment of COVID-19? These are the few drugs which has been named as antiviral drugs. Please understand, most of the drugs here may not be a direct antiviral, right? Few are direct antiviral drugs. For example, remdesivir, yes, it can be a direct antiviral. Lopinavir, ritonavir, yes, it is an antiviral. Protease inhibitors, yes. Favipiravir, sobusbovir. These are specific antiviral drugs. But in the middle of it, there is hydroxychloroquine. There is azithromycin. These are the few drugs. In addition to it, there are certain other drugs which are also being tried. For example, say your ivermectin, anti-parasital drug. That is also being promoted or projected or being suggested as one of the things, and few trials are also going on. Nitazoxanide, that is also an anti-parasite drug, which we will be using for your micrococci infection in your HIV patient, microsporidiasis infection in your HIV patients, nitazoxanide. So nitazoxanide and this anti-parasitic drug ivermectin, or the few other drugs which are being even tried, and there are few arms of trials also going on. So based on this, we can go to remdesivir. Remdesivir is an investigational nucleoside analog. It is a broad spectrum antiviral drug. And there are few trials which have been conducted across the Western world, say US and UK, has shown that there is a promising effect of this remdesivir. Till now, there is no 100% conclusive evidence, but as of now, in the hierarchical system, which is the available drug to treat a COVID-19, remdesivir is being projected as one of the first line of drug to be tried. Second comes the question whether it is available in India. No, not yet. However, for trial purpose, it is available. That is through WHO. They are conducting a lot of trials. On that basis, it is available. And on a compassionate basis, there is some kind of rumors that it is available. We really do not know. And I haven't used remdesivir. The mechanism of action is through your triphosphate mechanism and adenosine analog, which will be affecting your RNA-dependent RNA polymerase. So it will be affecting your protein synthesis and the formation of your new virions. Second comes your chloroquine. Chloroquine is an age-old drug which is living with us for maybe more than 100 years or so. We really do not know. And we have been using left and right for all our malarial programs, and also for your chloroquine-based drugs for your arthritis-related things. This thing. What is the importance of chloroquine? Chloroquine, as we know, that these are the few drugs. There are something called as broad-spectrum drugs, which has an antiparasitic activity, which has an antiviral activity due to different mechanisms. This chloroquine, which has been proposed or projected that it will affect the process, most of the process of viral replication, whether it is raising the intercellular pH or otherwise affecting your endocytosis or otherwise getting your integration. There are multiple ways by which this chloroquine can inhibit the SARS-CoV-2 virus replication. This is theoretically, it is being projected. Okay, what is the evidence which is available? There are, even now it is inconclusive that whether it is 100% useful or not. But however, harmless drug, we have got a wide experience with it. Even it is being prescribed by a village health nurse as a chloroquine in your villages. So due to its availability and accessibility, as because we have used as in Indians, this is one of the drugs which has been projected, and ICMR till now is projecting this or proposing this or recommending this as one of the treatment, right? What is the safety concern? Risk of cardiac arrhythmia. So what we do, we monitor the QTC level. We take an ECG. If a OP-based patient, if the ECG QTC level is more than 450, we don't prescribe. If it is an IP-based patient, if the QTC is more than 500, we don't prescribe. Or otherwise, yes, we here use as one of the standard treatment. Mechanism of action, the same thing at different levels, whether it is glycosylation or viral assembly or new particle transport or DNA and RNA polymerase. It has a multiple effects in one. So right from your entry to your exit, it affects. Second, it also plays an important role in down regulation of your cytokines. As you know that whenever there is an infection comes in, your T cells and B cells response, your monocytes response, your macrophages response, and whenever these T cells comes, they will be releasing your interferon gamma. This interferon gamma will be stimulating your monocytes, macrophages, tissue macrophages to release your cytokines, IL-1, IL-6, IL-10, and there will be a basic inflammation. When the level of it goes beyond control, hyperinflammatory phase, then the cytokine release syndrome kind of things happens with your HLH. So it also plays a role in subduing this IL-6 release also. Hydroxychloroquine, closest congener of your chloroquine, most of the side effects are not present, and however it retains certain risk of cardiac arrhythmias. The same QTC recommendation is applicable for hydroxychloroquine as well. The mechanism of it remains the same, both immunomodulatory effect and also antiviral effect. Azithromycin, which is we know that azithromycin we are using as an antibiotic, macrolide antibiotic, and we know that we are using it in addition to other things as an immunomodulator, right? So when we look into the, say, the basic, say, mechanism of action of azithromycin, it is not only as an antibiotic, immunomodulation, lung protection, inflammation protection. So this is proposed as one of this thing. But however, as both of the drugs prolongs QTC, we are not using HCQS and azithromycin combination to be on the safer side. But however, there are certain guidelines which propose HCQS plus azithromycin. Coming to your third group of drug, which is lopinavir and ritonavir. We know that this is an anti-HIV drug, which I have used maybe since 5 years or 10 years or so. We started our therapy with lopinavir, ritonavir. We have used this extensively for our post-exposure prophylaxis, right? But as the newer congeners of these antiviral medications has come, we have forgotten this because they have their own side effects. You are to say interferes with your say fat metabolism, interferes with a lot of other things, causes pancreatitis, and it is also one of the things which lead on to a lot of side effects. So now we have moved on to more safer drug rather than relying on this lopinavir, ritonavir. There is a rekindled interest on this lopinavir, ritonavir. Few studies from China thought that it might be useful. But however, Indian ICMR or Indian guidelines are not proposing, but you should understand that in the solidarity trial of WHO, lopinavir, ritonavir is included as one of the arms, right? So please understand that there is even no hope for lopinavir and ritonavir because WHO has considered it along with interferons. These also causes cardiac arrhythmias. Favipiravir, it is one of the drugs which has been promoted very well by your Southeast nations, especially Japan. It is a kind of inhibition of your RNA-dependent RNA polymerase. But however, there are anecdotal evidence saying that it is useful in the management of a COVID-19 infection. What is the status? As of now, to my knowledge, favipiravir is not available in India. And they were saying last week, they told that it will be introduced in India by Glenmark, but however, we are yet to receive our consignment. Sofosbuvir. Sofosbuvir is a drug which we have been using it for your HCV infection. and now it has been repurposed. Actually, I am conducting a trial on with the sofosbuvir, wherein there was molecular docking studies have proved that the sofosbuvir can affect your viral replication compared to your lopinavir, ritonavir, compared to your ribavirin, compared to your remdesivir as well. So in Vijaya, we are in the early process of conducting, and it is ethical committee approved. I have registered in the clinical trials CRTA as well, and we are going to start. 2 days back, I received the confirmation, the trial number and other things. In a few days, we will be starting the sofosbuvir trial as well. According to molecular docking studies, they are showing promising results. Our intention of taking this is the remdesivir. It is not available, too costly. Second, favipiravir, which is not available. So we are left with no other antiviral. So we thought that this is already approved by DCGI. So it is available. Why can't we take it for our discussion? Or I mean for our treatment. Now we have discussed about certain drugs which are affecting the virus. Now it is a time to discuss about how we subdue the inflammation. This is nothing but tocilizumab, IL-6 receptor inhibiting monoclonal antibodies, and we have got a couple of good experiences with tocilizumab, and it has been used with the giant cell arthritis, say juvenile rheumatoid arthritis, and we have tried for say 4 or 5 patients on tocilizumab. Only thing is that there is a possibility of a opportunistic infection, because as you know that when inflammation is being suppressed, there is a possibility of say infections. Then COVID-19 convalescent plasma. As you are aware that the plasma, whenever a patient recovers from a disease, the plasma contains antibodies. Whether these antibodies can be used to treat a suffering patient or who is in MODS kind of thing. Hello.
Yes, sir.
Am I audible, sir?
Yes, yes, sir.
Sorry, I think it got disconnected. I will just give me a minute. So convalescent plasma. Right. One thing is that there is a small bottleneck area here. If we wanted to use convalescent plasma, we have to get an approval. We have to be either in the trial studies with ICMR, because ICMR is doing a trial, and WHO is also doing the trial. Unless until you are regular in those kind of trials, we may not be able to use this convalescent plasma. But who have used it, they have maybe shared with us that there are some promising effects. Steroids. This is a very important aspect, steroids, because one thing is that in MERS infection, your Middle East respiratory virus infection, okay, which happened a few years back, and your SARS-CoV-1. In both these things, even in your H1N1, steroids doesn't have a good role, or actually it has a negative role. Actually, they were recommended against using steroids. When we formulated this expert committee, we were also against the steroids. But there was a latest study or latest observational study which was conducted in Michigan, which showed that steroids in the moderate phase prevents the patient from going into a severe phase. And I have used in say 50 to 60 patients, and the results were quite impressive, but we are yet to conclude it. I wanted to do an analysis, in-depth analysis, and find out. One of the hesitation of using the steroids is because steroid, as you know, that it is an immunosuppressant, yearly usage First, we discussed about viremic phase. Then there is some kind of lung phase or pulmonary phase and your inflammatory phase. If you are going to use in your viremic phase, is there any possibility of your immune suppression and uncontrolled multiplication of your virus? So these are the few other things. These are the other few supplementary therapies which we are using. One is antithrombotic, which is nothing but your low molecular weight heparin, which we are using for our admitted patients, especially admitted patients in the moderate severity of illness. Then there is another therapy which is also being tried, that is your absorption, adsorption, or removal of your inflammatory markers. That is through your cytosorb and Terranova. Terranova is yet to come. It is promoted by Baxter, which is cost effective. Cytosorb is already available in India. We have used for bacterial sepsis. Here we are going to try. We have already procured 10 to 15 cytosorb, and we are in the early phase of using it for our serious patients along with CRRTs. Corticosteroids, we have already discussed, though initially we had our hesitations to use corticosteroid. Now we are using steroids, but however, the dosage is very limited, 0.5 to 1 milligram per kg in a divided dose or a single dose, and it is only for 5 days. Nutritional supplements, vitamin C, as you know that vitamin C, zinc, and vitamin D3, or these are anti-infective vitamins. They prevent your cough, and right? So these has been promoting for a long time. So these have been also given as supplement for patients who are suffering from corona disease. So after discussing about the disease, the pathology, and the different therapies which are available in your armamentarium to treat this disease, either attacking the virus, controlling the virus, or otherwise controlling the hyperinflammatory state, how do we manage? Whenever a patient comes in, we look into it whether it is a low risk or high risk, that is age or comorbidity. Based on this, we would be segregating the patient as a mild, moderate, or severe. Mild only observation. Maybe if they are having a little bit of symptoms, symptomatic management and HCQS plus or minus azithromycin. If they are in the moderate phase, in addition to the basic therapy, we will be giving them steroids and also low molecular weight heparin. What is moderate? Moderate is, say, the room air saturation is less than or equal to 93%, tachypnea, pro-inflammatory markers are elevated, that is the thing. So whenever a patient comes in, we will look into the comorbidity, then pro-inflammatory markers. What are the pro-inflammatory markers? Your CRP, ferritin, D-dimer, okay, IL-6. So comorbidity, pro-inflammatory markers, then laboratory value. As you know that these viral diseases produces lymphopenia. So what we see is NLR, neutrophil lymphocyte ratio. If the neutrophil lymphocyte ratio is more than 3.1, it is a bad prognostication. Neutrophil lymphocyte ratio is more than 3.1. So we will do a complete blood count looking into an NLR. We will be looking into the inflammatory markers, that is your D-dimer, CRP, and your ferritin, and in severe cases, IL-6. Then we will be doing a CT, that is imaging, to find out the ground glass opacification if it is present. COVID presents as a classical ground glass opacity in your CT. Peripherally distributed, more prominent in your lower lung fields. There will be pleural thickening, interseptal thickening. So based on these four verticals, comorbidity, pro-inflammatory marker, laboratory values, and imaging, we would be segregating the person or the patient as a mild, moderate, severe. Mild will be receiving HCQS plus or minus azithromycin. Moderate will be receiving, in addition to it, steroids plus LMWH. Severe will be, in addition to it, the investigational drugs. What are the investigational drugs which are present? Either remdesivir or favipiravir, which is not available in India. So we use tocilizumab. If the patient is in the trial, then we might get an opportunity to use your convalescent plasma. So the therapy can be these things like HCQS plus or minus azithromycin, low molecular weight heparin, steroids, and investigational drugs. So maybe in the 100 or few cases what we have treated, that is, I mean, we are in the process of treating our 127th case. And here we would say that with this kind of management, the outcome is fairly good. And we are waiting for this remdesivir and favipiravir or any other, say, confirmed antiviral drug to tackle the disease. So if there are any questions, I would be very much pleased to answer them.
Yeah, Samita?
Thank you, sir, for a valuable seminar. I request Ramlakshmi Madam to speak a few words. Ramlakshmi Madam?
Unmute. Her
Hello.
voice is not. Yeah.
Hello. Thank you, sir. Thank you for the valuable information and an excellent presentation. We could get a lot of information from it. I hope all the participants have got a lot of information in the chat box, and hope this pandemic will come to an end with all this. Thank you.
Sir, few questions from our participants.
Yeah.
Sir, can I start the feedback questions?
Yeah, please.
Sir, this is from Dr. Divya, one of the assistant professors in KK College of Pharmacy. She's asking, drugs like moxifloxacin, doxycycline, erythromycin also have immunomodulatory effects. Is there specific reason behind using azithromycin in the treatment of COVID-19?
Yeah, that's a very good question. Of course, this doxycycline or otherwise erythromycin and moxifloxacin, yes, these also has those kind of immunomodulatory effects. As because the trial was started there, they used it that HCQS plus azithromycin. We are sticking on with azithromycin. That is one thing. And second is spectrum, we are using it. That is the second thing. Then third thing is that here the usage of this, as you know, that we will be usually keeping these levofloxacin and other fluoroquinolones for our TB treatment. So we are a little bit comfortable with using this, say, macrolide antibiotic. So when it comes to levofloxacin vis-a-vis azithromycin, we always prefer azithromycin because that goes to your MDR treatment profile. And yes, doxycycline is also considered as one of the good drug, immunomodulatory drug as well. And to be very frank, that it is also in the trial phase, which we are trying to use ivermectin and doxycycline, and where we are going to try on certain patients, because ivermectin brings down your viral load drastically. But only thing is that what we are suspicious is that can we achieve that kind of, say, level of drug in the body to bring down your viral load as we could achieve in a in vitro, right? So these are the few things. And ivermectin and doxycycline, we are trying with a few in an arm of patient as well.
Thank you, sir. Another question from Misbah Hunain. As COVID-19 is a respiratory syndrome and presents itself with respiratory symptoms, what does comorbidity do that increases the risk of mortality? Why does being diabetic increase the risk of mortality in COVID-19? Is it because they have lesser immunity, or does any other factor is involved?
So when we look into these kind of comorbidities, our overall understanding is that, one, whether there is a generalized immune suppression. As we know that diabetes or obesity is actually an immunosuppressive state. You know about this obesity, which is also an immunosuppressive state. That is a pathophysiology which has been even promoted by some of the Westerners. That is, obesity is an immunosuppressive. So obesity, diabetes is an immunosuppressive state. So these are the few things. Then CKD, your immunosuppressive state, right? So CVD, due to your hemodynamic compromise, it also compromises your ability to deal with an infection. So these four comorbidities, based on your immunity, you become more susceptible to this infection. So that is one thing. So these are, say for example, diabetes, hypertension, and your CVD, and your obesity. So there is one cluster. Then when we go to the next cluster, smoking. Smoking, as you know, that it damages the lung tissue and it exposes the person. They will be having a chronic bronchitis and already their bronchial and alveolar membranes are damaged, and easily this bypasses the barrier functions and causes an ARDS or a severe illness. So that is a second cluster of persons who are also locally immunosuppressed. Then your COPD and your asthmas, wherein already they have a respiratory pathology. So as madam was asking, one thing is that your immunosuppressive state, mostly it is your immunosuppressive state which makes you vulnerable to that infection. Second, your local immunosuppression or local structural or pathological or physiological changes like your COPD, asthma, respiratory illness, ILD kind of this thing, smoking, which affects the local pathology and may exacerbate the risk of getting that infection.
Thank you, sir. The next question is from Dr. M. Rangapriya. Sir, is there any significant role of natural nutraceutical immunoboosters that has been reported in COVID-19 therapy?
Yes. So, of course, as you know that we have antivirals, or otherwise our armamentarium of drugs against virus is not as extensive as bacterial infection, right? And we also understand the basic pathophysiology or our limitation in treating any kind of viral disease, whether it is HIV, HBsAg or HCV, that wherein most of the times we are not able to give a full cure. And we do understand that most of the time we are dependent on our immune mechanism, basic immune mechanism, whether it is an innate immunity or an adaptive immunity, to tackle these viral diseases. Vis-a-vis your bacterial diseases, where you have extensive antibiotics for the past, say, 70 to 80 years. Yes, the immune system plays a major role. But the second question is that, so those are the few things wherein we recommend vitamin C, zinc, vitamin D3 and vitamin A deficiencies, or correction of vitamin A deficiencies as few of the factors which will prevent you from getting those kind of viral infection, for example, COVID-19 as well. Both in your pharmacological, whether it is a modern medicine based pharmacology or your alternative therapies, for example, say, which we are not at all discussing about, which is your Ayush, comes under the purview of Ayush. There are anecdotal evidence stating that yes, immunomodulatory therapies will, or immune boosting therapies will prevent infections. But as you know that, as of I know, there is no any double-blinded trial which has been conducted to prove that effect. But of course, personally, if you ask me, I do believe, because we haven't yet gone into that extensive research aspect into it. So unless until we don't go into that extensive research aspect into it, we may not be able to favor for or against that particular therapy.
So thank you, sir. This is a mixed question everyone is asking. There are few cured patients in India. There are certain number of patients who are cured from COVID-19 in India. Are they completely cured? And how long the discharged patients are advised to stay isolated in their home? After
so, for example, say, there is something called as science. then there is something called as community intervention. Then there is something called as our say fear factor. Okay, according to proven science or according to the evidence which is available, which is very limited, as I have already told you that from the onset of symptoms, okay, the 10th day or otherwise resolution of your symptoms, post 3 days resolution of the symptoms, the patient becomes say anti-infective. So if a patient develops symptoms on 10, by 20th, he may not have that capacity to infect others. So that is. So now we are moving towards, previously we were saying that at 14th day, we will be doing 2 tests. That is called as exit test, RT-PCR. If 2 are negative only, we will be discharging the patient. But now, according to the CDC criteria and other criteria, we are moving to say that if the patient is asymptomatic at the 10th day, and if he is asymptomatic in the past 72 hours, afebrile, not needing any antifebrile medication, then he can be straight away discharged into the community. That is science. But you should understand, this is 97.2 percentile of the thing. Your bell curve, 92.7%, 97.2 percentage of the people. So there are outliers who might excrete this virus. So to be on the safer side, what we recommend is that to be on the safer side, it is not based on your science. To be on the safer side, what we recommend is that when we are discharging the patient, either on the 10th day, as of now, if he is turning negative, sometimes in the government facilities without doing the test also, they might be discharged. They will be usually advised to be in strict home isolation for another 14 days. But for all scientific purpose, by 10th day, they become non-infective.
Okay, thank you, sir. The next question is from Pratibha Madam, KK College of Pharmacy. What are the challenges in maintaining treatment services for the people who use drugs during the COVID-19 pandemic?
In the sense, which drugs, madam? Which drugs?
What are the challenges in maintaining treatment services for people who use drugs during COVID-19? Pratibha Madam, can you ask the question directly?
Yeah, yeah. Hi, sir.
Hello,
Actually, while treating the patients, you are assuming or you are giving some drugs. So even though they are not clinically proven or whatever you people are
Yes.
trying, so
Yes.
I had a basic question on that. So what
tell
about
me,
the impact? What about the impact of those drugs while you using that or after that? How it will be? How the challenges are?
Sure, because you see, I mean, like for example, as a person of science and as a person of an investigation and as a person who always tries to find out a remedy. Okay, we have our own limitations. As of now, we know that COVID-19 doesn't have any kind of direct antiviral. So that we know that is a baseline. Now, we are left with certain options which says that due to some theoretical projections, which is acceptable by the scientific community, that these are the drugs which have been effective in treating this virus, right? So going to the next level. But however, for doing a double-blinded control or a newer drug, we may not have the luxury of waiting for another 1 year or 2 years, because the projections, what we are saying is that to produce a herd immunity, 70% of your population has to get infected, right? If in India, 70% of the population gets infected, then it says that you are, say, now you are 120 crore people, at least 80 crore people has to get infected. Even if we put a mortality as even 1%, it will be very, very shocking, right? So in this kind of challenging, situation, we are limited by certain drugs which are claimed by certain people, which are on an investigational platform or an in vitro platform that it is effective. That is one thing, right? Second is that So we don't have any kind of treatment. Second, there are certain drugs which have been projected that they can be used. So I think as a treating physician, our only question is that whether it harms the patient immediately or not. So we are making ourselves doubly sure. For example, if I'm going to prescribe HCQS, right? What is the basic justification in that? We have been prescribing this HCQS for your malaria. I have given HCQS for your chloroquine for your malaria. Anyhow, they are taking, anyhow, this thing is there. One. Second, we are using in your SLE patient, rheumatoid arthritis, all those kind of disease modifying agent. So now it is being proposed here. And moreover, this is only a short course, 400 milligram on day 1 BD, then 400 milligram or 200 milligram BD for the next 5 days. What is the imminent danger? QTC prolongation and arrhythmias. Are we monitoring it? Yes. Now we are prescribing. So I think the time has to tell us that whether our interventions are really worthwhile. As I have told that this till now, the HCQS, yes, it might have a later effect. It might have your, say, retinal damage effects. We are yet to see those kind of effects. But I do understand that, yes. So that is only we are very much concerned that not using this concoction of medicines. For example, say, as because HCQS has an antiviral effect, ivermectin has an antiviral effect, oseltamivir has an antiviral effect, lopinavir, but putting everything as a combination is no. But however, single this thing, according to their limitations of monitoring and availability, the physicians are treating that. But we are in the earlier stage. We are very much concerned about it, especially when we are using azithromycin. For example, say the resistance what it is going to be, lopinavir, ritonavir, resistance what it is going to develop, or oseltamivir in the general community per se. Because community, the effect won't be happening now. The effect will be happening after 2 years, after 3 years, when another pandemic visits us. And tocilizumab, especially the secondary infections, usage of steroids, exposing them to lot of infections. Yes, we are aware of it and we are very concerned about it.
Thank you for your valuable information, sir. We don't want to take up more of your time. I'll end the session with this last question, a general question. Your general advice is related to anxiety in the current scenario. The last question, sir.
The thing is that, for example, when people will die is that, what is the risk of dying? The risk of dying exists as long as the people are alive, right? So once you are dead, there is no risk of dying. So this is how. So as long as we exist, there is a risk of dying. And what I tell to my doctors, my colleagues is that, yes, everything has a risk, right? Everything has a risk. Walking in the road is a risk with a number of accidents which are happening. And driving a vehicle without a helmet is a risk. Even then, for all our, young blood, we will be doing those kind of things to attract the opposite sex. So there are certain risks which is existent in the community, existing in the surroundings, and we are taking basic precautions towards it. I think that we, as an individual, should scientifically approach this disease, know that this is a viral disease, this is a person-to-person transmission, this is a droplet infection. So I know how to tackle this droplet infection by social distancing, by frequent hand washing, and taking other remedial measures to keep myself healthy, those kind of things, what we are going to do. So with this kind of basic precautionary measures, with the hope that tomorrow is also our day, we have to go on. There is nothing to panic. And I have seen a lot of even old age persons, for example, say 85, 90, 75, they have come out of the disease, they have walked home. Yes, these are risk factors, but if they are adhering to their basic preventive measures, and if they are adhering to what doctors say to them, and they are adhering in a scientific manner, I don't think that there is anything to worry about or panic about. And what that same fear, what we should have about maybe going for swimming, or maybe riding a vehicle, or driving a car, or driving a two-wheeler. I think that applies to this as well. We have to take precautions, and we have to, of course, humans endure. At anything happens, humans endure.
Thank you so much, sir. Thank you all participants for being patient. May I request our beloved principal, Veena Madam, to give the vote of thanks.
Sir?
Yes, madam.
Okay. I have one very basic question. How a
Ask
pulse
me.
oximeter is useful, sir? Pulse oximeter to find out
Yeah,
the
that is very, very important question, madam. That is not at all a basic question. Very important question. Very clear. That's because we haven't yet gone into the management into this thing. Because even actually the overview took me after almost 20 minutes. I don't want to elaborate much on it. So that was the thing. But you are asking a very, very relevant question. Pulse oximeter. There is something called as happy hypoxemia. The problem with this COVID-19 is that, okay, the patient doesn't develop breathlessness in the earlier phase of the disease. The patient will be comfortably sitting without any kind of tachypnea, any kind of, say, respiratory distress. But if you go and check his saturation, it will be less than 90, 88, 85. What is the basis? Usually our saturation should be more than 94 at room air. Then why these patients are if our saturation falls less than 94%, we will become little bit distressful and we will be hyperventilating, or we will be having some tachypnea. But these patients, these are the very, 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 very riskier patients, wherein they don't show signs and symptoms of hypoxemia. In order to find out that whether their lung is affected, whether their respiration is compromised, we have to have a pulse oximeter. And it is recommended, actually in our expert committee, we were thinking that why can't we provide pulse oximeter to every single government organization under the sun? Okay, PHC, 5 watt and pulse oximeter, fingerhead pulse oximeter. So pulse oximeter is one of your vital, which is recorded even in your PHC, to find out these kind of persons who are sitting like a time bomb without having anything, and suddenly they collapse, and they will be giving only a short window of opportunity to save them. So pulse oximeter is very important, and actually we recommend our say economically say wealthier people to have their own pulse oximeter at home, especially in a high-risk population. And whenever they get fever, when they suffer from these kind of symptoms, one of the home isolation policy is that frequent pulse oximeter checking and documentation. And if it falls less than 93% at room air in the home, they have to immediately seek the hospital say advice. Yes, madam, very important. There are a lot of things which are very important. That's because pharmacology I couldn't
strands of
discuss.
viruses are there, sir. Only particular strand is very virulent. So do you have any idea about which strand is virulent? There any data are available?
Here, earlier phase in your, say, when it started in China and other things, there were epidemiologically some, say, studies which were going on. They have documented almost 15 to 16 different types of viruses. But however, for all practical purposes, there are two types, which is L and S type of viruses, which are mostly prevalent in most of the population. And as of in India, we haven't gone into those kind of epidemiological things or biological process to know that how many different types are existing. And we would actually in the expert committee, we were suggesting to the management, to the government, whether they can explore these kind of possibility of knowing these kind of different strains of viruses of COVID to itself, COVID-19, that is SARS-CoV-2, so that we can have a different strategy. But it is in a very early phase because we are fighting to even save our patients who are suffering. This kind of say supplementary route to find out the broader picture is it's unfortunate it is missing. But that is a very relevant question, madam. That will give us a lot of insight and help in an epidemiological perspective. We are actually looking into it.
Okay, sir. On behalf of KK College of Pharmacy, my heartfelt thanks to Dr. Babu, CMO of Vijaya Hospital, for the wonderful presentation. Sir, you have given a clear explanation about the transmission of the disease, how to treat the disease and everything. And you have given a non-stop wonderful presentation, sir. Thank you, sir. I know in spite of your busy schedule, you have accepted our invitation. I have given a presentation, sir. Thank you. And I'm thankful to all the participants, those who have registered for the webinar today. And I would like to thank all the organizing committee members for the wonderful seminar. Thank you, sir. Thank you.
Thank you.
Thank you very
sir.
much for the opportunity, madam. Thank you very much. Thank you
Thank
for
you,
the
sir.
invite.
Thank you.
Thank you very much, sir. You got a lot of good comments from the participants.
Thank you,
Wonderful
sir.
speaker and very informative session. So really, it was. We have received all
Thank you,
comments,
sir.
very good comments. Thank you very much, sir.
Thank you,
Thanks a
sir.
lot, sir.
Thank
Sir,
you.
before we
Thank you,
wind
madam.
Before
Tell
we
me,
wind
madam.
up, I have one question.
Tell me.
Whenever I have a temperature, I myself, I'm taking the habit of the tablets like paracetamol, azithromycin. Is it advisable to take the
No.
paracetamol or even a vitamin C now as a supplement?
Madam,
Yeah.
if you ask me, I mean, a frank question about whether I could take this tablet, I would say no. In the sense that, for example, as you know, that every tablet has its own side effects.
Yeah.
And moreover, there are only handful of documentation. Maybe that all the side effects, what we have put together in this, all those Sims book, pharmacopoeia, everything is only maybe a 5% of what has come to our knowledge. There are umpteen number of things, minimal damage, cancerous potential, oncological potential, interstitial nephritis. Even a single tablet of a vitamin can cause an interstitial nephritis. We really do not know. So as far as possible, stay away from those kind of supplements. And as far as possible, if it is feasible, we have to go for a natural product. But I would recommend that, for example, say, keeping a healthier diet, which is a wholesome diet. For example, whether you have got an adequate vitamin C supplementation, adequate, say, your vitamin D3 supplementation. If those things are deficient, yes, you have to seek these kind of pharmacological method to have 1 or 2 shots of vitamin D injections or vitamin supplementation. But one thing is that there shouldn't be any deficiency. Addressing to the deficiency is by having either a wholesome diet or otherwise taking your pharmacological therapy. But what is advisable according to the hierarchy is your natural food habits and a wholesome diet. And if it is deficient, better to have, because vitamin D3 deficiency, vitamin C deficiency, I mean, most of the times we will be having your, say, basic citrus food. So most of the times it is not there. But vitamin D3, which is very, very, very prevalent, yes, it possesses a lot of danger to get an infection. So better wholesome diet, if not at least supplementation, but not as a routine.
Yeah. Thank you.
Thank you, madam. Pleasure, madam. Bye.